Yeah, so this is a patient that I recently saw. It's kind of a jumbled mess of a situation where the big issue here is that the patient has she has I would hang my hat on it that she has early onset Alzheimer's disease. But in the kind of her journey along this path has been interesting in that she's been told a couple of different things. This is probably the most relevant, which is initially she's a retired attorney. And in 2019, she was supposedly doing okay by basic standard, but she had been fired a couple of years ago and disbarred actually from practicing law because of making errors, and she actually couldn't do a couple of like really basic tasks that needed to be done for a trial. And so then she ended up getting referred to a neurologist who made a diagnosis. This is all outside providers who said this is probably MCI, ordered an MRI, and then they said no one ever went over the MRI with them. This will come relevant in a moment. She then about maybe a little over a year later did a MOCA with a primary care provider, which was a 7, but then they said that was just because she didn't try. And so she kind of got lost a little bit in that, but then saw a different provider at a different clinic and saw an ARNP who said this is probably mixed dementia, put her on donepezil, said she should probably stop smoking weed, which is probably still a good idea. And then later she went to yet another neurologist, reviewed the MRI, and the patient's family took away from that patient had a stroke. She didn't have a stroke. And so when they got sent to me, asking about whether she should be driving, which the answer to that is absolutely not. But the primary issue that I have is, so the family is extremely adamant that she's like, oh no, this is all because she has a stroke, and that their perception of her is that she's actually doing very well. But when you hear the history, she's gone through 5 credit cards because she's falling victims in the past year, because she's falling victim to scamming. She was disbarred from being a lawyer. But their perception of her is that she's doing just fine, and that she just had a mild stroke. And so the big question here is kind of not really, I don't know if it's necessarily like walking back a diagnosis per se, but kind of how to best help her and her family really understand where she's at, what's happening, and to get the buy-in that kind of what their perception is right now is not entirely accurate. And because my big concern is how much she's doing independently, or trying to do independently. They live on the Kitsap Peninsula. They're pretty isolated, and kind of thinking about more like safety, planning for the future. Her husband is very involved. He's also a lawyer, is also very involved in, her care, but his perception is probably the most distorted of them all. So that's kind of the story for her and where I'm at. And since she's not in-house, this is an outside referral. And so I'm in terms of like resources and things like that, thinking about what's available in Kitsap, who might be best for her to link up with there, et cetera. That's where I'm at, is kind of how to help them in a patient with a system that I am not really involved in. And she doesn't really have as you can tell, a consistent group of providers either.
Although maybe in some ways it's like, yeah, when does somebody get a neuropsychological evaluation? Like this is like a really it was worth it for her to have this evaluation with you. But yeah, now how do we?
But now what? Yeah, exactly.
Yeah.
Yeah. Kind of like, now what? Because I just feel like she needs, and I feel like it's kind of two pieces. One is kind of just to get everyone on the same page. And I'm happy to have a conversation like that. I just don't know, I tried to plant some of those seeds when I was just talking with the husband of kind of like, I'm not very convinced that this is stroke related, but, and to get him, but they're it's also interesting, just a lot of the commentary is really interesting, because she'll say, so her mother, the patient's mother, had late, probably my guess is Alzheimer's, based off of the description, but more later onset in her 70s, mid 70s or so. And what's interesting is hearing the commentary from the husband as well as the patient's sister. Both of them were, I got to talk to, and they both have a pretty consistent history and perspective on things, but was them talking about the patient's mom and being like, well, she's not nearly as bad as her mother was. And we just think she's really worried that, and that's what's causing it. They're like, oh, the patient's just really worried that she's going to have difficulties like her mother did. And you say, well, but she is possibly worse, and so that it's just a very interesting dynamic in this family. And so trying to bring some light to certain things in gentle but informative ways, and then getting them so that they're in a better place. And I thought this was actually kind of a decent case in the context of Barak stuff around like advanced care planning and thinking about having those conversations about what the future is going to look like and how can we best plan for that and put you guys in a really good place.
Well, and it nicely also highlights, like, getting a diagnosis of dementia due to stroke is very different than a diagnosis of dementia due to Alzheimer's in terms of future care planning. Right. Sorry, Karen.
Yeah. Oh, yeah. No, that's okay. That was important. And I sorry I didn't hear all of your explanation about it because I was having some audio issues. But I think you said they were in Kitsap County.
Yes.
I hope that Denise Hughes is the Kitsap County dementia specialist, and she comes most weeks. I think it'd be great for her to step in. I feel like she's probably has a lot of wisdom, and it would be great for her to sort of help with that. And then we can also, even though Kitsap County is one of the few places that has this sort of like one designated dementia specialist, who is, again, great that she's part of our group, but also sort of like directing other folks, more broadly, that there are dementia specialists at each of the aging and area agencies on aging. Sort of like that's exactly the kind of thing that those should be referred to. Of course, more complicated in King County though, where we have like so many agencies trying to do that and not all doing it as well as others. But it's great. I do, like I said, I really hope Denise shows up today because she would be the ideal person to jump in and help with this.
Yeah.
And sorry, I won't be able to stay for the discussion, Carolyn, but I mean, I'm sure as Mimi would attest to, like the very first step for advanced care planning is just to make sure that everybody's on the same page in terms of the diagnosis and the prognosis. Like there's no good conversation that can happen about advanced care planning unless everybody is on that same page. And so, you've just identified for sure that there needs to be a family conference where these results are reviewed and a diagnosis is made and a prognosis is provided, and making sure that people have a chance to get their questions answered about it if they have uncertainties about it.
Yeah. Excellent. Yeah, I think those are the main things. I don't, there's not, I mean, otherwise, other than she probably really should stop smoking weed all the time. But at this point, who am I to tell her what to do when it comes to marijuana?
Well, we can talk about brain health.
We can talk about, right. We can talk broadly about brain health.
Yes, I mean, that's the way to talk about it. Say, I'm concerned about your brain health, and you, I think, are probably somewhat concerned about your brain health as well. And this is something that I would recommend for your brain health.
Yeah.
Carolyn, you make a recommendation. My recommendation is, or my strong recommendation is, which is, I think, a little bit different than saying you must or you have to. Could try that.
hey guys, we have, it's 12:15. We have just 4 people in the waiting room, 5 people. So I'll go ahead and let everybody in and then give them a couple of minutes before we kick in. Here they come.
Barak, really great job this morning.
Oh, thank you.
It was just so good. So
Awesome.
good. I'm sure you heard that.
You're the second person, so thank you so
Oh,
much.
come on, come on. And you're humble.
And so, Allison, I'm going to have the slides on my computer, right?
Yeah, that's
Yeah,
what I
good.
was
Okay,
thinking.
perfect.
Okay, good. Yeah. Hi, everybody. So we're going to give it about 1 more minute to let people pop in before we kick it off today. Barak, will there be a recording available to your morning presentation?
Yeah, I'm not sure how Virginia Mason Franciscan handles their grand rounds, whether they are public. I mean, there was definitely a recording made, and I don't know if it will be publicly available or not.
Okay.
All right, well, it's the magic minute of 12:17. So we'll go ahead and get started. Unfortunately, as you can see, both Chris and Nancy send their regrets. They are not here today, but we will try to soldier on. And so I will share my screen and talk about the agenda. We are going to mix things up a little bit today, just because of Barak's schedule. He will need to leave at 12:50, so we wanted to give him a lot of time to do his presentation and also be present for questions. So just a few quick notes to start with. We'll sort of skip over introductions, go right to Dr. Gaster's presentation about advanced care planning, and then Dr. Parsi has a great case presentation. So please do, as some of you are already doing, please put the names of all attendees from your site into the chat, especially if there's more than one of you there. Also, when not speaking, please do be sure to mute your microphone. And then when you unmute, just let us know who you are. And if you can, it's great to turn your video on. We do like to see everybody, but also understand that bandwidth and safety matters may preclude that. And please, yes, protect private health information. Everything is recorded and available on our website, so we do not want to disclose PHI. And at the end, we will remind you about our 1-minute post-session survey. And without further ado, here is Dr. Barak Gaster, professor of internal medicine, and I will let him take it from here.
Thanks so much. And great. And so, yeah, so apologize to those who have heard me talk about this before. You know, it gets a little bit better every time I do it. So hopefully you will learn something more. And so today we're going to talk about advanced care planning specifically for dementia. And so I want to start out thinking a little bit about why dementia really is a somewhat unique case for advanced care planning. So, you know, when I first started working in this area, I had people say like, oh, gee, do we need advanced care planning for, you know, COPD and advanced care planning for, is there a different advanced care planning for every disease under the sun? And it's true that, yes, there are specific interesting sort of angles for each disease, but dementia really stands apart from all of them, mainly because early in the disease, people lose the ability to guide their own care and others have to make decisions on their behalf for many years. And in addition, it can be a really rough course, that about 80% do go through a phase of really what can be severe psychological symptoms like agitation, and can even become combative. And so most people really would want a gradual shift to comfort-focused care as they go through a dementia illness. But then it can be so challenging to just figure out sort of when and how to decide how to make those shifts. And so it really is this like giant tsunami of people who are going to be under our care, who are going to have to figure this out. And it's really the next 10 years that the doubling of people living with dementia is just sobering. And so in so many ways, it really is the #1 disease challenge we face, especially when it comes to advanced care planning. And it's really about how to not necessarily give less care, but it's really about giving better care. That really, when we align the medical care that people get with the medical care that they would have wanted, that really is better care. And so it's the first thing to think about is, well, why doesn't a standard advance directive just sort of take care of all this for us? And part of it is that if you really read the fine print of what every state's standard advance directive has in it, there's really almost no guidance in there about dementia. Like, it focuses on important situations, but situations that are really quite rare. So a permanent coma or a persistent vegetative state are important conditions to state what your wishes would be, but the odds that any of us are ever going to be in a permanent coma or persistent vegetative state are so small, whereas the chances that somebody is going to face dementia in the future is actually relatively high. So it's really the #1 reason that people lose decision-making capacity. And it's hard because dementia is such a complex illness. People early in dementia may have many years with good quality of life left, and there's then this slow decrease in quality of life as people go from a mild to a moderate to a severe stage. And really, most people would want different goals for their medical care along those stages. And it's just so important to hold on to the personhood of dementia, that this is not, a sort of black and white moment where all of a sudden your life has no meaning. Absolutely not. This is really a situation where people gradually have a change in their quality of life and in their prognosis, in which it makes sense to really try to think ahead of sort of what would somebody want. And really, people have really strong views about it. This is a study that was done in Boston of 200 people over age 65 who did not have cognitive impairment, and they were shown a video series as to what moderately severe dementia looks like, and then and they really tried hard to make this a very balanced depiction of what living with dementia is like. And then they interviewed, or that they had people those 200 people fill out a questionnaire, and 72% indicated that if they were in sort of that stage of dementia, that they would want comfort-oriented care only, which, as we know, is not necessarily what happens. And it's a hard thing to sort of figure out how to have that conversation and to sort of help families to feel confident that that's what that their loved one would have wanted. And so really, it is this challenge of how do we help people to communicate those wishes. And so that's why I helped to develop this dementia-specific advance directive with input from people in palliative care and neurology and geriatrics that I tested and refined in primary care practice and have made available for anyone to download from the website dementiadirective.org. And so since this website went live 4 or 5 years ago now, over 150,000 people have downloaded it for free all over the country. It really has taken on somewhat of a kind of a viral life on its own, because it's not like I'm really out there promoting it or advertising it anyway. But the key sort of thing that happened was we wrote about it in JAMA, and then the New York Times wrote about it. And so that was 4 or 5 years ago. And then really ever since then, somehow, I think most people are just finding it by sort of typing into Google dementia directive. And the way that the directive is structured is it gives a brief description about what mild dementia is often like, what moderate dementia is often like, and what severe dementia is often like. And then under each of those stages, it gives people the ability to choose what they would want the goals for their care to be at that stage. And the most recent version of it went live a little over a year ago now, I think, which really helped to clarify, giving people some real direction as to the why for the care options. And so it is a checkbox of intervention, but it really does try to get at what their preferences are and what their values are as to why they might choose those preferences, with the most important one being that if somebody does indicate no CPR, no intubation, it's really that the key sort of point that if somebody has a dementia illness and then they suffer a cardiac arrest or say a severe pneumonia that requires them to be intubated in the ICU, that even if they do survive a catastrophic event like that, their odds of being significantly more impaired after that episode is very, very high, and much higher than somebody who goes into it without a dementia illness. And so that's a reason why that the value might be that somebody wouldn't want to have that resuscitation, cardiac or respiratory done if their odds are just so high that even if they survive, they would be significantly more impaired than they were going in. And somebody might choose a comfort-focused care only if they really are concerned about what the high risk of adverse events and complications are of getting hospitalization and other types of invasive care that can be very difficult for somebody with dementia. And so since this was written about in the New York Times, like I said, thousands and thousands of people download it every month. My email address is actually on the website. And so I get, every, I would say several times a month, I still get an email from somebody, thanking me for the directive and, just saying really sort of meaningful comments about how useful they find it to be. An interesting point about my thinking about how when is the best time to give somebody a dementia directive. Initially, my thought was, gee, at that very earliest sort of mild cognitive impairment moment, that is the time that I used to think was the most important time to offer something like this, because that's the point at which I have a very high concern that somebody is going to need a directive like this. And, an interesting experience that I've had and many other people sort of have validated is that, one of the very first things that gets lost for many people when they start to develop cognitive impairment is the loss of the ability to imagine a future state of themselves. And so at first I thought it was just that they were sort of, anxious or sort of afraid or that they didn't want to think about it for psychological reasons. But the more that time went by, I really came to understand that it's more than just a psychological barrier, as much as it might be a physiological sort of problem where it's something that we take for granted of being able to imagine future states. But it's actually a relatively sort of high level executive function task that people do lose early on in the course of in many courses of dementia. And so rather than offering it to people with mild cognitive impairment, I started offering it to all of my patients who were over age 65, who were there at their annual wellness visit. And instead of getting almost none of them filled out when I was giving them just to people with mild cognitive impairment, I started getting all of them filled out, because people really do have a lot of feelings about this and really are happy to be able to have an opportunity to share them. The biggest question I get is it legal? So like, what is the legal status of this directive? And it's so important to think about, what is the legal status of advanced directives in general? And the most important point is that advanced directives in general are really just general guides for families. They inform us of patients' values and preferences, but I don't think that anyone would really sort of think of them as being a rigid algorithm that must be followed. They're not legally binding. They really are there to provide guidance for proxy surrogate decision makers and clinicians as we make decisions at the bedside. And it was really for that reason that we decided to not put witness requirements on the dementia directive, in that that witness requirements are really a barrier to completion. If we require witnesses, fewer of them will get done. It's a huge reason that people sort of set it aside. It's like, oh, I'll get to that later. And that really the risk of conflict and uncertainty, if people don't have a directive, is greater than the risk of conflict from an unwitnessed directive later being challenged. And here I point people to like a really brilliant essay that was written on this subject in the New England Journal about 5 years ago now. Well, the title of the essay is, let's delegalize living wills and not require witnesses. But very important to distinguish this point from a durable power of attorney form. So in some ways, a durable power of attorney form is a form of advanced directive. That terminology can get confusing for people. The difference between a living will, which is what some people think of as an advanced directive, versus a durable power of attorney, where people are putting in writing who they would want their surrogate decision maker to be. So the durable power of attorney form is much, much more of a sort of legal document, which really can be used as a rigid algorithm of this is the surrogate decision maker. And so that it's absolutely useful and important for it to be witnessed and notarized. And so in terms of how I would think about the legal framework of a dementia directive is to think of it as a supplement to a standard advanced directive. Although, somebody only has a dementia directive and doesn't have a standard advanced directive, I think it still can be useful as a standalone document as well. And, if somebody is really worried that their dementia directive might be legally challenged in the future, or that there would be conflict in their family about sort of interpreting it, then absolutely there's nothing to stop anybody from getting any document notarized. And so, if somebody sort of were to ask, I would say, for sure, if you are concerned about this, feel free to go and get it notarized. But it really seemed important to not have a section for that on the form, as then it would seem like it was a requirement for the form and people would just sort of set it aside and never get to it. In terms of the value of it, I really think of it as really people feel better having a chance to express their preferences. I think of it really as a tool to communicate to their loved ones. Not a rigid algorithm. The biggest value is to facilitate a memorable conversation with their family. And then there's just this added bonus that not only are they having this conversation, but they have like a piece of paper in front of them as they're having the conversation that is sort of documenting sort of what they are saying at the conversation that then a family can look back on later. So, but what about when somebody does have early dementia and maybe they're still able to fill out a dementia directive, but probably it's going to be a difficult task for them. The most important form to pull out for somebody who has especially mild cognitive impairment, but really even early dementia, is that durable power of attorney to set the proxy decision makers. Somebody may have lost capacity to fill out a dementia directive, but they will retain capacity for much longer to say who they would want their surrogate decision maker to be, because it, again, doesn't require that complex imagining a future state of themselves. And so really early in dementia is so important to help people to fill out a durable power of attorney for healthcare. And in some ways we might think of like, gee, most of our patients don't necessarily need this, because the person who they would want to be their surrogate decision maker is the person who it legally defaults to, which is usually their spouse. And it's fine for them to not have a durable power of attorney if there is clear alignment between who the legal default is and who they would want. The problem with dementia is that this is, as you all know, like a 10 to 15 year disease, where it is very possible that by the time they reach a state of moderately severe dementia 10 years from now, it's very possible that their spouse is not going to be there to be their surrogate decision maker. And so the question then really comes up of who would they want the alternate to their usual sort of default to be. And, you know, a lot of people don't have children, or they have 8 children. And it's an interesting question of which of their 8 children would they want to be their decision maker. And it may be that it's like their best friend or their neighbor who they would trust the most and have conversations with, you know, rather than some distant cousin as the backup to their spouse. And so that's really the key sort of moment of mild cognitive impairment or very early dementia, where you really do want to help somebody to fill out a durable power of attorney, not just who is the first up, but who is the backup to that person. And I really want to highlight in such a big way the Conversation Project. It's a website of an organization in Boston that has, you know, tools to help families sort of guide them through conversations about all advanced care planning. And they have a one that is specific to dementia that I really highly recommend. And I think that the biggest sort of, you know, take home sort of question to have in your back pocket is, you know, if somebody could look down on themselves now, what do you think they would have wanted for themselves? Like, that's really, I think, such a powerful sort of way of talking about this that I think really helps families to sort of understand how they can guide the process. Put a big plug in for the Pulse form. So valuable and important for people with dementia. And again, in the past year in the state of Washington, this changed from being a physician order for life-sustaining treatment to a portable order for life-sustaining treatment, making the point that that physician assistants and nurse practitioners can sign this document as well. And you know, this is a very legal document. It's a crucial tool that anchors goals of care conversations. And so even though sort of code status needs to be sort of reset each time a person changes from one location to another, from home to the hospital to a living facility. This is such a valuable communication tool across those sites so that you're not completely reinventing the wheel each time somebody changes location, that they can sort of portably go with their Pulse form to help set what the new conversation that's going to happen. And it's really setting goals of care now. So what if your heart were to stop? What if you weren't able to breathe on your own? Would the preference be for ICU care? Would it be for comfort care? And again, this is a very similar framing of what are the value statements, what are the whys of why somebody might choose the different options on a Pulse form. And again, really making the strong sort of recommendation that if somebody with dementia has a cardiac arrest, that even if they are miraculously sort of shocked and get their hearts working again, that period of anoxia is so likely to result in significantly reduced cognitive function that that's not something that somebody might want. And again, that statement of or that question of imagine if your loved one could look down on themselves now, what do you think they might say that they would want? A real quick comment about tube feeding. Again, like I think many of you know this or have heard it before, that such good, solid evidence that shows randomized controlled trials that people with dementia who lose the ability to take in nutrition through their mouth actually do worse if you put in a feeding tube. That this is so clear that it doesn't prolong life, it doesn't make people more comfortable, it causes more suffering in the form of aspiration pneumonia, and that you know, that strong expert guidelines, consistently solid data-driven research. And what's hard is that we know this, and it's easy for us internally to sort of have that sort of have that as our approach, but it can be really difficult to talk to families about it. And so I think the biggest challenge is how to have that conversation with families in a caring and empathic way. You know, having a phrase ready like, you know, tube feeding doesn't fix what is a slow dying process for your loved one. And it's been shown to make people less comfortable. And I worry that if we were to put it in, that there would be really significant complications of it that would make somebody have more suffering. So key points about advanced care planning for dementia are: before somebody has dementia, consider a dementia directive for everyone over age 65. For mild dementia, that durable power of attorney form to set the alternates is so important while people still have capacity to fill out that form. For especially moderate to severe dementia, the PULSed form is appropriate and incredibly valuable, and a really good use of an annual wellness visit for somebody with dementia. And just remembering that key phrase: imagine if your loved one could look down on themselves now, what do you think they would say that they would want? And again, just a huge plug for the Medicare annual wellness visit as a really important way, a structured way to talk about advanced care planning for somebody with dementia, that you're going to spend a lot less time on healthcare maintenance and cancer screening, and a lot more time on advanced care planning. And that if you use an advanced care planning code that sort of modifies along with the annual wellness visit code, you can actually get twice as many RVUs for that visit. And it's very simple to document. The documentation required for that is very, very simple. And again, this increases the RVU for that visit from 1.5 to 3.0, and there's no additional cost to the patient, no copay or deductible. You just have to document that you spent more than 15 minutes discussing advanced care planning at the visit. And if you go to the website, cognitionprimarycare.org, there's a really easy to follow one-pager that shows what codes to use, and a example of the very, very simple documentation that is all that is required for that billing code. All right, so that's what I've got for advanced care planning for dementia. And there's the website for the dementia directive. And I think we have time for questions.
Wow, thank you, Barak. Phenomenal. Knowing that you are here with us for another 8 minutes, I thought we'd just open it up, see if there are questions.
I'll go if that's okay. Thanks, Barak. As always, I feel like I learn a little something new every time I hear you give a version of this, and I always appreciate it. And I would say I have a lot of similar feelings in you on the topic. And I would say the thing I hear most from the dissenters, or from people who have other views than maybe you or I do, is what about this concept that you might not know what you would want as your dementia progresses, and that quality of life changes, but that quality of life, it's really hard to know in our well state. So I'm sorry if you mentioned that today, but how do you respond? How do you think about that question that I hear a lot?
Yeah, and I think, I mean, it's a totally valid question. And I think that, and I think that's the main reason why it's important to not think of this as a rigid algorithm that you would sort of need to follow. That if somebody is having, this wonderfully, rich, and meaningful life, in moderate dementia, that, it's not wrong to sort of say, oh, well, actually, they marked this, but maybe that's not really sort of, if they could look down on themselves now, what they would say. And so it's really important to make the point that you're not locked into this. And by far, the most important thing with advanced care planning is who is your, who would you trust the most to maybe modify, what you said before. But I also think that it's important that that yes, even though none of us can exactly foretell, what our quality of life would be, that it still is it's more. I think any of us would still want to have that opportunity to express our wishes and document our wishes, and to have those preferences taken into account in the conversation. That. Because I think otherwise, if somebody doesn't have a directive like this, but you kind of remember them saying comments before, you're your ability to really conjure up your memory of those conversations is always going to be so kind of like fuzzy and like, what did they say? I tried to remember what they said. And so, I mean, you're always going to try to bring back what you think that they would have wanted. And I really just would say that it's better to have some to have some opportunity for that person to sort of be at the table with you as you're trying to make that determination.
Barak, it's Mimi. I appreciated hearing this, even though I heard some of it this morning. Anybody that can do this twice in one day is really a trooper. So thank you so much. And I know you just mentioned tube feeding, just kind of very briefly. Is it okay if I add something?
Oh, yeah, for sure.
Yeah. You know what we always encourage clinicians is to talk about what we are going to do in terms of careful hand feeding. And then we would not recommend, the tube and always just like so many other situations, focus on what we are going to do, not what we're not going to do. We find that helpful.
Absolutely.
Yeah, Mimi, that's a great point, because I think some people say, oh, well, if we're not going to do tube feeding, what will happen? How will my loved one eat? So to really walk them through. Yeah. So Lynn Corti has put some great information in the chat about the DAC and resources that are freely available. And we'll also have these links up on the website afterwards to refer to.
Barak, thank you so much again for your talk. I was wondering if there's been any work starting to interpret or translate some of your resources into non-English speaking patients.
Yes. Yeah, and I have, and the key important point to make is that it's rather than a translation, it's really a culturally appropriate version. I think this, especially with a document like this that carries a lot of sort of emotional baggage with it, it's really important for it to not be like a word-for-word translation as much as it is like a culturally informed sort of adaptation. And so I have worked with Mandarin speakers, and I have worked with Russian speakers, and even Portuguese. There was somebody contacted me from Brazil who wanted to help to develop a Portuguese version. And so I have versions of the directive in those other languages, and it's sort of on my long to-do list to post them on the website, but I haven't yet. But so if anybody would like the Chinese language version, or the Russian language version, or the Portuguese, Russian, and Portuguese, Russian, and Mandarin. Yes, I have those versions, and I'd be happy to email them to anybody.
Oh, that's amazing. I work with a lot of Chinese speakers, and so and I feel like dementia resources for this population is really hard to find. So anything would help. Thank you so much.
So Barak G at uw.edu, and it's Barak without the C. So it's like Obama, but without the C. So it's BARAKG at uw.edu.
Great, thank you.
Bang.
Thanks, Barak. Great presentation. I learn every time. I do have a question about the RVU. A while back, Nancy talked about the code 99483. Is that separate from this annual wellness RVU?
Right. Yes. Right. So you're referring to the cognitive evaluation code, or I can't remember the exact, it's the cognitive evaluation management code, which is separate from annual wellness visit. Yeah. And
So the other code is every 6 months, can be used every 6 months, the 998-483, that one.
yeah,
Yes.
right. So the trickiness about that code is that Medicare has lots and lots and lots of documentation requirements for using that code. And so it's not that like a team can't get good at doing that, a visit like that. The annual wellness visit has like a tremendous amount of required documentation as well. Most primary care will do so many annual wellness visits that they will have figured out how to do the required coding for or the required documentation for an annual wellness visit code, but it's a harder stretch to put together like a good streamlined way to do the required documentation for the cognitive evaluation and management code.
Thank you.
And I would say that if you do the annual wellness visit code and then you tack on the advanced care planning modifier code to that the number of RVUs is still slightly less than the cognitive evaluation management code, but it's still pretty, it's close-ish.
Thank you.
Wonderful. Well, thank you, Barak. I know you have to go on to your next event, but really, really appreciate this, and we'll be posting it online.
All right. Thanks, everybody.
All right. Back to our announcements, which we skipped over to give Barak enough time. So our next meeting, we're so lucky to have Karen talking with us about community resources. And then at the end of the month, we'll have Mimi talking with us about palliative care. And soon we'll be releasing the didactic schedule for the remainder of 2022 as well. And we're always happy to get your thoughts and recommendations on topics you would like to hear. And even more so, case presentations. We love to have presentations from our community members. Allison is always open for business. Please do let us know if there's anything, any cases you would like to talk about with our group, and also follow-up cases too. So in terms of accreditations, we do offer a continuing medical education, and each session is worth 1.25 credits. Speakers today do not have any financial relationships. All relationships have been mitigated. Also, we offer accreditations with the School of Nursing. And a special plug, we are so thankful for Julie Holgado to be organizing this nurse practitioner conference coming up on May 14th. And you may recognize some of the speakers here, Dr. Rhodes and Dr. Eisenberg. So if you are in the area, would love to see you there. And again, we've already talked about if there are multiple people on your link, it would be great to put your name into the chat. And Allison will be tracking you down if we don't have your email address. Please let your colleagues know. We love to have new people joining. And this is our team, and you've heard from a lot of us today. And up next, you'll now hear from Carolyn Parsi, one of our neuropsychologists at the University of Washington.
All righty. Good afternoon, everyone. So as Kimmy said, my name is Carolyn Parsi. I'm one of the neuropsychologists at the Memory Brain Wellness Center over here at Harborview, where the sun is officially shining, and I'm very excited about the potential for this weekend because I've heard it's supposed to be glorious. Let me pull up my slides. I'm going to be presenting a case today that I recently saw in my clinic, so for neuropsychological evaluation, but I have a lot of the content and information from the patient's other evaluations too. I'll be talking about kind of the story that brought the patient to me, and then kind of posing some questions, especially if for those folks who are more familiar with resources and availability of things on Kitsap Peninsula, or kind of in and around the kind of southern Kitsap area, I will be looking to you in particular. So this is a 60, when I saw her, which is very recently, she's a 66-year-old female with about 7-year history, from what I can gather, of progressive memory difficulties. Her working diagnosis at this point, for a spoiler, is early onset Alzheimer's disease. That's by my evaluation recently. And I'll talk a little bit about kind of how there have been some interesting ups and downs in terms of diagnostics. She is the main issue is that she's been seen by a lot of different providers in different settings, with kind of, I'll say loosely, or maybe just completely disjointed communication between providers, and kind of an inconsistent story that's been provided to her, and some misunderstanding along the way. So I'm really, this is less of a diagnostic question and more about practical management, talking about getting her the best support, and also having good conversations with patients and their families about diagnosis, and getting everybody on the same page. So a little bit about her. At least when I spoke to her, she doesn't have grand significant complaints. She is rather minimally conversational, at least spontaneously. She doesn't provide a lot. The majority of the time that I was with her, her sister came with her. They're very close. They look like twins, but they clearly have a very good relationship, but her sister definitely speaks for her most of the time, and without kind of giving the patient a lot of time or dedicated space, the sister will definitely talk for her. So I spoke with the sister as well as the patient's husband too. Both are kind of in pretty much agreement of when things started and how things have changed, although I got some very different details from the sister versus the husband. It's always interesting to me of what details patients, families are more interested in sharing. So especially when you get them separately and talk to them separately. But regardless, either of them said maybe around 2015, 2016. So this has been going on quite a while. Started with some short-term memory issues, forgetting conversations, some confusion. The sister provided a conversation or an anecdote about when the viaduct and how the viaduct in Seattle was going to be coming down, and how that conversation had been happening in the news for so long. And then when the day finally came, that the patient was very startled that she saw this on the news and that the viaduct was coming down, and that she said, well, when was it? That seems erratic, and where did that come from? So not really tracking that had been a conversation in the news for quite some time. So that's really what stood out for the sister. What the husband shared with me, which the sister did not, was that the patient was actually fired from 2 different jobs. She was a practicing attorney for the majority of her career, for a good 30, 35 years. And in around 2016, 2017, she had to do a common procedure at court, something that the husband, who's also an attorney, described as a very simple task, something where they're just presenting evidence, and it's not actually like a really intense part of the case, something that most attorneys can do in their sleep. And she made a lot of errors to the point that she was fired immediately after that. She was ultimately disbarred in 2018 because she didn't fill out any of her paperwork to retain her license to practice law. And then she decided to go work part-time as a paraeducator, and was at an elementary school, and she got fired from that after not following several of the rules. She had several engagements where she was, I guess, so they have a larger principle and ruled that they're not allowed to touch any of the kids, and not holding their hands or, giving them a pat on the back. They apparently had very, very clear rules about you can't touch the kids. And so she did that once, and there was a complaint. And so she went in and they talked about it, and they said, you can't do this. You cannot do this again. And then it was within a week or two. And she, apparently the story is that she reached out one of the little kids at recess, reached out to like hold her hand to like walk back into the room, and she took the kid's hand, and then she was fired shortly after. So this is those are some of like the pivotal moments in this history, which really sound like happening, more like 3, 4, 5 years ago. And then ever since this, it's just been a very gradual decline in cognitive function. Although the family, so sister and husband, really have a very, I will say, a very positive, naive, perhaps unrealistic perception of how she is doing. So as an outsider, me seeing her for the first time, to me, as soon as I walk into the room, I say, oh my gosh, this is dementia. And this is not, this is pretty significant, and this is very progressed. And, but for them, they say like, no, she's just a little bit forgetful. The larger context of how she's doing at home. So she lives in southern Kitsap area, pretty remote in terms of where they live on a supposedly a very beautiful property. Her husband has started assisting with a lot of the IADLs. So he's double checking her meds, but he still is having her try to remember to take them. But it sounds like if she is allowed to do that on her own, she's missing things. She's taking them irregularly. She was just started on a slightly different medication for diabetes. It's metformin, but I think the dosage is slightly different than what she was on. And that has been confusing for her, and integrating that. I'm going to talk about finances in a second, because this is a big point of contention, it sounds like, right now. She was actually referred to me to talk about driving and whether she should be driving or not. But she ultimately is not driving because she has a Prius, and the battery in the Prius died, and she refuses to drive any other car, and her husband is just not going to fix the car battery, is the plan. He's doing most of the cooking because she gets really confused. The physical activity and physical function is actually quite good. She really likes to go for walks. She used to love Zumba. Hasn't been doing that as much thanks to the pandemic, kind of threw off her Zumba groove, for lack of a better term. So she spends just a lot of time watching TV, tootling around on her iPad, things like that. Seems like basic ADLs are okay. Her medical history is listed there. Nothing acute or significant in terms of neurologic or vascular injury of any sort. So she has type 2 diabetes, high blood pressure, high cholesterol. Her labs are more or less normal. She had a slightly low B12, and she was started on supplements for that. There's basically no psychiatric history. She is a regular user of marijuana just about every day for many, many years. She does not use any other substances, no history of that either. There was a nurse practitioner who put her on donepezil recently. I'll talk about that in a second. And then her other meds are listed there too. The patient's mother had dementia. From description, it sounds like Alzheimer's disease, more of a late onset, maybe in like her mid 70s or so. But otherwise not significant. So I mentioned she's a retired attorney, did law school at UW. She's been married to her husband for quite some time. There's 2 kids that are in their early 20s, one of which who lives somewhat nearby. She's closer to Portland, and then one on the East Coast. Patient themselves is one of 5 kids, and she's really close to her sister, the one that I got to talk to, and that sister lives in Seattle. So a little bit about her journey to me, which I think is worth talking about, because this can happen, and it's always, in my opinion, it's quite sad when this is kind of how things unfold. So she despite all the context of her in like 2018 and having issues in 2017, she cruised through an MMSE with her primary care in 2019 and didn't flag for anything. But in 2020, early 2020, just shy of the pandemic onset, or right around the onset, that she saw a neurologist for some kind of mild concerns, and she was given a diagnosis of MCI. They ordered an MRI. It was over a year later, some of that thanks to COVID, and also just because she was they just kind of carrying on, is what it sounds like. She ended up back at primary care, and her MoCA dropped to a 7. And the primary care chalked that up to her not being engaged. And rather than thinking that it was concerning, she ended up seeing a different neurology practice about a month later. And that's when she was given the first diagnosis of a mixed dementia, and they put her on the donepezil. She's supposedly been on that since, but how well she's been taking it, it's unclear. They also told her she should probably stop smoking weed, which she didn't. In September, she then saw yet another neurologist in a different clinic. They finally reviewed the MRI with the patient, and the family and the patient then, the patient's family then took away from that all of her cognitive symptoms were due to a stroke. I'll make it very clear, she never had a stroke. So that has been their story ever since, which is that, she had a stroke and that's why she has all these problems, and she's going to be, fine, but it's just going to be like this for a long time. She ended up getting referred to me for concerns about driving. And this came up through a primary care physician. And I saw her not just a few days ago, actually. Her MoCA was a 9 with me, a generous 9, I will say. And just global cognitive impairment, repetition, confusion, basically could not complete most formal tests that I could have given her. A lot of stereotyping and conversation, very much agreeing with, it's kind of the general agreement with anything that's being posed to her. So that's her story. And so when I started planting seeds, I try not to jump cart before the horse when I talk to patients in my clinic about diagnoses before I have, kind of data in front of me. I like to do due diligence. But I started to try and plant seeds of, I don't think this is a stroke. I think this is neurodegenerative. And I got quite a bit of pushback for that. Initially, because they're very, very clenched to the idea that this is a stroke. I remind you, her husband is an attorney, and he pulled out his very large briefcase. This is something that's very typical of attorney patients or patient family. If you're familiar, they will pull out like the accordion file of all of the documents of every single medical visit they've ever had, and they will pull it out and they will throw it in front of you and say, no, the MRI says, and the MRI says mild ischemic white matter change, which is somehow has been distorted into this is a stroke. And so I was trying to have a very pleasant conversation with him about how I think there's something else going on here, and kind of starting this, but there's been a lot of kind of clash in the belief right now, and what else might be going on. There's also some commentary about how the patient is actually the reason that she isn't doing well in any sort of cognitive evaluation, whether it's with a primary care, with me, with anyone. It's just because she's anxious that she'll turn out to be like her mother, which I think is more a projection of her beliefs rather than anything she has expressed. But yeah, so where I'm at, and where I would love some discussion, is I do believe strongly that this is early onset Alzheimer's disease now in its moderate stage, probably starting a good 7-ish years ago. Ultimately need to provide this clear information about diagnosis and prognosis with the family, get them to buy in to the more realistic story, so that they can have good expectations, or more appropriate expectations of the trajectory. Also want to get them hooked up with resources on the peninsula. They're they are mobile, and that both the husband and the sister who comes and visit them often can take her places, and both are willing and able to. And then to kind of tie in with what Barak was talking about kind of advanced care planning, she does have a pulse. She has no other documents. The irony of all this is that the husband is a guardianship attorney. And I'll just let that sit there for a moment. And so the conversation around what to do or how to help them with decision-making going forward and how to best support her, especially without a consistent care group as well. They've kind of hopped around into these different clinics and had, including myself. So this is, she's not internal to us at UW Medicine. And so kind of her hopping around and trying to get some sort of a better or a clear team that can help her medically as well. Happy to answer questions or just hear thoughts, recommendations.
Thank you so much, Carolyn, for describing a very challenging situation. So yeah, hoping to open it up to maybe initial questions and then recommendations.
Carolyn, this is Mimi. I'm curious what her pulse says, and I'm sorry if you mentioned that and I didn't hear it.
I did not specifically say. She, I believe she, now I'm trying to remember. It was one of the papers that was flashed in front of my face very quickly. I believe it is full code. And so yeah. Or very close to it. It's definitely not DNR DNI. I can tell you that. Yes.
Carolyn, this is Branja. So when you ask the sister and the spouse how things are going, it sounds like they're telling you things are going well.
Yeah, the short story is that things are fine. She's just a little forgetful and just needs a little bit, she just needs some reminders from time to time. It's very interesting because I feel that anyone who would interact with her just kind of immediately would sense that that's not the case. But yeah, they see it more as she has just this minor forgetfulness, but nothing that we can't overcome.
And had they seen any changes over the past months or year? They
have. This is where the distortion comes in, okay. Or the discrepancy is that, well, they will describe that more in activities that she can't do. It's less this attribution. There seems to be this disconnect between how her cognitive function is likely impacting IADL. So for example, her husband, if you ask about changes, her husband will say, she's yes, she's forgetful. You have to more probe for how is she doing at home, because they'll just say that, well, she used to read mysteries, but now she just plays on her iPad or watches TV. And you say like, well, why do you think that is? Right. And then the answer is that, well, she's just not interested in reading anymore. So there seems to be, in the same, if you ask about like the finances, I didn't end up talking about the finances. I can talk about finances or medications. It's just like, oh, well, she just needs a little bit more help, so we're just going to do it. Like they're super pleasant and they're all lovely people. And you can tell they want to help, but in some ways, almost doing too much help is putting this veil over what's happening. And I feel like that at some point is going to be a very problematic situation.
Yes, so they refuse to allow you to give them the gift of time to plan.
Yeah, exactly. Beautifully said. Yes, yes.
Mm.
Rather not have everything come to disaster and crisis management, as we all like to avoid.
Hi, this is Elise. I'm one of the geriatric medicine fellows. Did you get the sense that the patient and her family have sort of hopped around between care teams, maybe because they've been hearing answers that they don't necessarily want to hear?
This is an excellent question and something I don't have a clear answer to this. It does not, I will say it does not come across as if they are hopping to look for a specific answer. Because the husband anyway, spoke positively of specifically the provider, the nurse practitioner. He spoke very positively of her, and I said, I asked why you didn't go back to her, because it sounds like that was a good conversation and you appreciated how she did her evaluation. He gave kind of glowing remarks, and he didn't have a clear answer other than he thought, he loosely mentioned scheduling, but it seemed odd. I don't have a clear answer. I wish I did. It's an excellent question of why hop around.
It's Rhonda again. I'm just wondering, sometimes the hop around comes from the lack of planning, right? As things come up, then you're like, okay, we need to get this taken care of, but then it's no longer a priority, so you kind of go back. And so from, my filter, I feel like these folks would probably really benefit from like a palliative care outreach type visit where you're in the home, you're able to kind of build some rapport, because it sounds like that's going to be really important because they have hopped around so much, where's the kind of trust for them? And someone says, okay, these are all the things you've heard. Let's see where we are right now and tell me, what's most important, and I'll get you some resources, and let's see where we are, 2 months from now. And then you've kind of like built that relationship already. And then maybe they're more willing to hear, oh, what you saw happen over the last few months, that's really typical of this particular disease process, and I worry about, what's down the road. It's funny. People are, in my experience, a little bit different when you get to see them at home versus when you see them in the office setting. And sometimes you just get a little more real. So I feel like if they would be open to that, that might be something that really would benefit them if that's available where they live. That's the tricky thing. Sometimes it's not available, but.
Yeah, no, I really like that idea. And that was going to be my next question, is if anybody knows if a resource like that does exist, or through what system, or what group in that area, if anyone knows.
We do have, I know Virginia Mason Franciscan Health has palliative care outreach in Kitsap, although it's sometimes limited and sometimes virtual, but it would be worth just exploring to see. Okay. And I know in Jefferson County, like that area, their hospice program just started up a palliative outreach program. So there are more than what there were before. So maybe something along those lines. I don't know.
Okay.
And M is putting some great suggestions in the chat as well. And again, we'll be sure to capture them and share them. M, I don't know if you wanted to discuss, maybe you've tapped into these services?
Yeah, I have worked with the majority of, sorry, my dog is barking. The area agencies on aging. They're pretty great in facilitating with families and individuals that have memory loss or any form of dementia. Primarily the family caregiver support program, you do have to screen into that, and there are requirements around it. But they also offer individual services such as transportation, adult day health, in-home care options, things of that nature. But and in each county within Washington State, the area agency on aging will do these things. They're different depending on the county, but it's always a good resource to go to.
Excellent. Thank you.
And Deborah's also reinforcing that the Kitsap Area Agency on Aging.
Mhm.
Deborah, anything else you wanted to make sure we knew about?
Not for Kitsap area resources. Usually those type of palliative resources can come from the Tacoma area. Almost all of our palliative and hospice resources actually come from Tacoma-based systems up into Kitsap County. And my hunch is this family is going to continue to try and have life as they wish it, as long as possible, until there's like a sentinel event, a fall, or she wanders away and gets injured. That's how they're going to choose. Based on history, I suspect that's how things are going to progress. But at least the area agency on aging can be known to them for when that does happen. They'll at least know what their resources are, and then they can reach out at that point.
Yeah. This is also exactly what I'm worried about too, is that is going to be how this unfolds.
Carolyn, I had a question about your case. I was wondering if you had an opportunity to meet with the family or the aside from the patient, like, you know, because sometimes the family, like in front of their loved one, will say like, oh, they're doing fine, but then, you know, behind, you know, back doors will be like, oh, we actually get it. I was just wondering if there's any cues that maybe they are getting it, they're just being reluctant to talk about it out of worry or protection for the patient.
Yeah. You know, I would never praise COVID protocol situation, but actually this has lent itself to some opportunity to talk to patients with, or talk to family without patients present. So in this case, I talked to the sister with the patient, and then I talked to the husband separately without the patient present. So still, I will say he was more forthcoming about her, more of her dependence on him. That also might just be because he lives with her, and the sister can speak less to exactly how she's doing at home day to day. But he was forthcoming about that. You just had to probe and ask for it. So if I were to give him more of a general question of how is she doing at home, the answer would be like, oh, she seems to be doing okay. But if you get more detailed and say like, is she doing her own medications, and be like, oh, well, and then, you know, and then like, well, is she driving? Oh, about that. Or the finance situation, she has apparently had fraudulent charges on her credit card. Multiple times. She's ended up having to get 5 different credit cards in the past year because fraud keeps coming up somehow, kind of unidentifiable charges and having to close down cards. And he seemed a bit befuddled about how all that's happening. And I'm kind of suspicious that it's less that there's fraud per se, and maybe she's buying things that she doesn't remember, and he's not tracking or doesn't know about it either. Is a little bit more of what it sounds like, or maybe a mix of both. But yeah, so it is a little bit more forthcoming when she's not present. There's definitely the sister will kind of talk for her too. And so it's difficult to get a little bit to get a word in with the sister, but in a very pleasantly concerned sisterly way, rather than like aggressively trying to steer a conversation.
Carolyn, this is Allison chiming in. I just want to applaud your specificity of questions, because I think for families, they really lose a sense of what is normal anymore. And some things are so atrocious and egregious that the stuff that's just plain shitty just doesn't even seem like a problem anymore.
Yeah. Yeah. And this is, and exactly what you said, just that I think that sometimes it's so hard, and I have an appreciation for this. It's unrelated, but I have a very old dog who's basically on hospice palliative care for dogs. And I was talking with somebody the other day about this, about how when you live with, you know, something for so long and it's just part of your day to day, you lose the nuance of how this looks to an outsider, or, you know, and I think this is another example of that, where, you know, from the outside perspective, you know, you see this and it's just clear as day, or I do, you know, and it sounds like several other providers have as well. Perhaps the specificity hasn't been as great in terms of what's going on and whatnot, but yeah, and how that just being embedded in it, you know, kind of the seeing the forest rather than trees, and yeah, kind of the need to zoom out.
I think Nicole actually had brought up a point about this. Nicole, I didn't know if you wanted to unmute and ask your question.
Sure. Carolyn, Nicole, I'm actually spiritual care, but something I have noticed often, my question was, were you able to see what you were actually noticing and the way you think things might progress? And I asked that question, partially I am curious, and also what I often see is people, they go to different people, they get the MRI, they get the this thing, they get the that thing, and they really don't know. Like, they really don't know what's happening. They are living with this person every day. And I think sometimes people are hungry for just one of those people to say, hey, listen, this is what I see. Have you thought about this? This could be the progression, and help them to that next place. Because sometimes it's not even sometimes that somebody's in denial so much as they just need somebody to kind of hold their hand. I mean, not if they're a paraeducator, but I'm just joking. But they, you know, somebody to hold their hand and say, help me make that leap, because I don't know what it is. And that's why I keep going to all these places, hoping somebody's going to give me the magic bullet and say, this is what your future holds.
Yeah. No, and I think I haven't had that opportunity yet. I will have a follow-up visit with these folks probably next week or the week after. That will probably be my opportunity. I started with some seed planting like that. And I will be give it a little bit time to settle in there, and then probably come back to it. And I liked a lot of the ways that you were saying some of that. Just like, this is what I'm seeing. Here's the path. Here's the chronology that I'm seeing. And, you know, acknowledging that they are seeing some things in her, but I think it's just to actually lay it out in a more formal manner, I think is what they need to see. So I will keep your wisdom in mind when I see them probably in a week or two.
Hi, it's Kara. I'm wondering if they have seen the dementia roadmap.
Not to my knowledge. I did mention just a couple of things, and I gave them. I was actually out of them in my office in the moment, but it will be something I will bring up in the conversation. I like to use it. I'm somebody, I like to actually in a situation almost like use it in that pull open the like double spread of the progression line, and use it as a visual. So yes, it's on my mind for sure.
Aaron, did
I
you
was
have
going
a
to add the
last?
same. Yeah, I was actually going to say the same thing as Kara. That sort of, it does seem like the dementia roadmap would be particularly good for this patient because of the fact, number one, it's like it's very general. And so like, it's okay if they haven't quite accepted a diagnosis. It's sort of like, if she's needing help with these things, she's kind of solidly moderate. And then I love that part about the dementia roadmap where it's like, if someone's in moderate, you as a care partner should be paying attention to advanced care planning, that whole, and kind of list things down about sort of like what things they should be thinking about.
Yeah.
Right. And then often as they go back and read those beginning stages and the symptoms, it gives them a better idea of, makes it more clear what the diagnosis is, and helps prepare them for what's to come.
Well, thank you, everyone. Thank you, Carolyn, for your eloquent description of what's been going on, and we'll look forward to updates. Thank you, everyone, for your great ideas and recommendations. Sort of highlighting why it is so important to make the diagnosis, to speak in ways that are understandable, to revisit questions if they come up later, but also to move on to, well, what do we do about this now, and look ahead to the future. So in just the minute or so we have left, I believe that we do have the survey, but Catalyst is down. So via your email, there will be a post-session survey. We love to get your feedback and look forward, hopefully, to seeing everyone back again on May 13th. Karen Clay will be providing us with community resources. Thank you, everyone. It was a great discussion. Everybody was jumping in. That was.
It was really
that
good.
was so great.
Carolyn, great case. Really well presented.
Well, I'm glad that one showed up. I've been, poor Karen has been hearing from me for like the past week of like, oh, like this case doesn't feel like good for conversation, and this one's like fine, but I'm not the best person to lead this one, and like all this. And so like, thank you, Karen, for being like my sounding board, my perpetual like annoyance of email all week.
Happy to do it. Thank you to the universe for presenting this great opportunity.
Yes, and then it was like that. I think I saw this patient on like Tuesday or Wednesday, and I was like, oh, perfect. Thank you.
Love it.
Carolyn, I'm really worried about that POLST form.
I am too. I will tell you one thing that worries me, or that just is, I'm somebody, I'm not very good at like playing poker. Like you can read me like a book. And sometimes when I hear certain things for patients, I have to like check my, like use all my frontal lobe strength to like not let it show right here. And in this case, like the patient's husband is a guardianship attorney. And I was like, and this is where we're at. Like this is what you do for a living, which worries me. That's another thing, but and kind of like, this is where we're at. And this is what we're talking about with like, kind of care plan or lack thereof. And I don't know. I'm worried as well.
I'm curious who had her sign it, and obviously somebody signed it.
Someone signed it. I did not get a look at it. He went off and started doing a bunch of other things. He might have, he might have it. Let me see. It might be buried in like a scan of something.
Because generally we think about POLST forms for people with serious illness with a life expectancy of about a year, maybe up to 2 years. And I think Barak thinks POLST forms for dementia patients, even maybe earlier than that, are appropriate. And I honestly would agree with that. But particularly a POLST form that pretty much says the full meal deal. We encourage people to complete a POLST form when they have decided to limit treatment. Otherwise they get the full meal deal, and the family is not left with this document that the person signed that says, I want everything done. And now the situation has dramatically changed.
Yeah.
So anyway.
Yep.
Yeah, and I feel like especially with this
about post, yeah.
And especially in someone like this, who there's nothing else, and all you have to hold on to is this document that's compelled, like now this, well, that's what we got to do.
Yeah.
Right. And have they even had any discussions about what's important and what if something unexpected were to happen and you were left in, severely impaired? Yeah. Yeah.
Yeah.
Good luck, Carolyn. We can hardly wait to hear how it turns out.
Oh my goodness.
So I really think the palliative care consult, and Carolyn, we may be well able to provide that care.
Okay.
We have, and obviously Franji didn't tell you that it's her sister that's the palliative care outreach ARNP in Kitsap.
Perfect.
She just joined us, so I think she's still out there. We have some limitations, but in general, if there are no other resources, let me know and we will figure out how to make it work.
Excellent. Yeah, I really like that, because I completely agree with some of that. It might just be that on a couple of reasons. One is just what's clear. What did come across clear to me is the importance of, for them in particular, to have like a connection with the person, and how like they spoke very glowingly of this one provider, and and I cannot be this provider of any sort, like the person they need, but that they need to have someone who is that central point, and to have a really good rapport with them. And you can tell just from them that is important, and very well might be driving some of the hopping too, without it being overtly said. I think it's entirely possible. But
yeah, Carolyn, I was just curious. So the thing about, like, we're here for a driving evaluation almost, even though it seems like the family was like, they know she can't drive and they have a great plan. They are just, the car's dead.
Yeah. The car is dead.
Yeah. So what were the circumstances, like, and so, but they decided to proceed with your evaluation, which is great, but how did that come about? And what is driving them to say, let's go through with this?
Yeah.
Were they looking for answers and resources?
They mentioned nothing. It's an excellent question, because when they came and I said, so what, so what are you hoping to get out of being here? That's one of the questions I always ask, right? Are you diagnosis seeking? Are you like, no, we pretty much know what's going on, we just are looking for X, Y, and Z, right? That's helpful for me. That they did not allude to any, like, spontaneously anything related to driving. And then I offered that I'm being asked a question about driving, and that's when the husband was like, oh, well, the car battery's dead, so it's a moot point, like, we're over that. And I was like, okay. So I don't know. It doesn't, on one hand, I think the most clear thing the husband mentioned was just, he was very just stuck on the MRI thing. It was hard to kind of get him to disengage from that, but of understanding trajectory and like prognosis. And so what was hard was that I was trying to decouple that from, I don't think this is a stroke, I think this is something else, and therefore the prognosis is very different. And that is kind of what, but I wasn't about to like open this huge because I was also talking with him individually and not when the patient was with him. And so I didn't want to start opening that whole conversation and running there without her present as well. So that's why I said I was like kind of planting smaller seeds for her, for him, but not launching into like a whole conversation already, because I wanted everyone to be there rather than just him, and then having it be a very awkward, weird conversation of the three of them going home to the peninsula, where he has information, the sister doesn't, the patient doesn't, and I wasn't about to start that. Yeah,
sort of like laying the seeds for a whole other topic.
For a whole other dedicated,
delivering the diagnosis, touching base about the diagnosis over time. Yeah. But without being like, let's talk about your Alzheimer's disease every single time. Like, we don't need to hammer that in. Yeah. Well, Karen, I don't know how you're gonna like your talk. My goodness, how you're gonna fit that into 20 minutes.
I know. I don't know. I'm just gonna, I don't know. I mean, it's pretty, I did that talk before, just sort of like how to connect with resources, and I was thinking about reorganizing it to such that like sort of when people are just getting diagnosed, patient-centered ones, and then as they progress, patient-centered ones, and then sort of family ones for the whole trajectory of the illness, and then also cultural resources was sort of like how I was going to try to organize it. But yeah, I mean, you know, like, I mean,
so
all of
much
our,
to cover.
yeah, I know. And all of our talks have had a lot of resources and whatnot. So I think also is sort of deferring to other people's talks for specific things. I don't know if you have any other suggestions for me.
I had a hard time fitting in 20 minutes. I have to let Nancy, and Chris know in advance. It turned out it was good because
especially
there's no
you,
way I could have done that in 20 minutes.
Yeah, right. I mean, yours just needs to be so detail oriented. Where I do think like what I'm doing is sort of providing guidance on how to find those resources rather than going into too much. Also think, you know, about your presentation, Allison had some really great resources. A lot of that piece seemed like it really resonated with people.
And then sort of now the online versus in-person resources and how there are ups and downs with both of those.
Right. Yeah, online, in person, and then written versus online. You know, I think that before we always were like, we want to be handing out something, you know, tangible for people to go home with. And I just followed up with the Alzheimer's Association yesterday, and they said that they're actually moving away from even creating things like brochures, that they're sort of moving more towards deferring people to the website and then making sort of PDF files for providers to download. So that's, you know, at least there's that. But I do think like, you know, I appreciate the fact like there's something colorful that goes into our packet that's sort of like, oh, I've got this, you know, colorful thing that looks friendly that I know I can call somebody. Especially, I feel like especially though like helpline information is like, it needs to be in something that's just easy to give and compelling enough by the
something you can't I often say like you can't stick a website on the fridge. That's what you know, like when you come with like you have like your magnet with the number on it, right? That's right. Sometimes that's good to have.
That's right. Yeah.
You know.
That makes me worried about people who are, you know, the neediest people.
Yeah.
That
worries me. That was my first reaction too. That's actually very worrisome, especially I'll admit. So I've been trying to get a couple of my like human-centered design students to look at like the Memory Hub website and Memory Brain Wellness website for like some user usability study stuff to do some improvement for older adults. And I'll be honest, the Alzheimer's Association website is not well designed, especially for adults. It's
even
bad.
For me, right? Like, I'm a professional like resource person, and their website is so incredibly difficult to navigate and frustrating.
And it's very
and
frustrating.
I even know what I'm looking for in a very specific way.
Mm-hmm.
It's terrible.
And I completely agree with you that it's hard to navigate. It is, and it's also a lot of the links are circular or they lead down different paths depending on how you click through them. And there's kind of these, you know, like broken paths that exist that are, yeah, it's driven me crazy for a long time. And so anyway, that just my side thought about that when you said that, kind of going down the idea of not just technology literacy or access, but even for those who have, even those who have all of those benefits on their side. Then you just start pulling back the layers of those who don't have the access or aren't computer savvy or, you know,
not English speaking.
Not English speaking. They're
have a little bit of memory impairment.
Or have
Yeah.
weird.
Yikes.
Yeah.
I have less than a minute, so I want to compliment Carolyn.
Oh, thank you.
Yeah, it's good. Did you talk to Barak in advance? Because they tie so well together.
I didn't, but I remembered that he was talking, so I was like, oh, and then this just happened to, yeah, a little bit of stars aligning. So,
You know, gals, can I ask, I would love to know what you'd love to hear about palliative care, end of life care. Just more general or something, a specific topic? Any ideas?
Well, this is, yeah, and maybe the other people on the call are much more experienced than I am, but how, because families, I think it's like, how do we do the friendly handoff? And like you're saying, like, you know, describing feeding, how do we describe like the real basics of like, well, what would this actually mean? You know, because I think people are overall, thankfully, friendly to the words palliative care and hospice often, but then it's like, well, what does that mean? Some people think, well, that means I'm gonna have somebody coming to my home all the time.
kind of like the expectations of what I think is the, yeah.
What you should expect from a palliative consult or hospice care?
Yeah.
Yeah.
Or how,
And-
Sorry, I cut
what,
out.
or maybe the kind of like what it can look like, because I know it can look different, like depending, you know, and I recognize that there is, but kind of because I agree with Kimmy, kind of this my little like elevator pitch around, and so this is what we're thinking, and this is what that might look like. And a hypothetical kind of scenario, like a typical scenario, if you can derive such a thing.
I would say, oops, sorry.
Go ahead. No, go ahead.
I would say maybe you can mention the difference between hospice and palliative care, because I feel like a lot of staff may not know the difference. I guess my experience is when I think I told you this one time that my dad, he was on palliative care, and I took him to urgent care because he couldn't urinate, and basically the urgent care doctor told me, why is he here? He thought that my dad is on hospice. He shouldn't go to the hospital urgent care. He asked me, why is he here? So he ended up, you know, I mean, he got some comfort care, and then that night we went home. He passed away that night, you know. So I was like shocked when you know, I guess maybe there's a difference. You know, I thought, yeah, I just like you.
There continues to be still so much misunderstanding, and in spite of our now decades of, you know, trying to help people understand. So, okay, thank you. Appreciate that. Yeah. Spring, I'm sorry for that experience. Yeah. Oh my gosh.
Yeah, I was just going to add that I think that a lot of people still like don't realize that palliative care is also just a good resource for advanced care planning early on in the disease. Doesn't have to be as like things are getting dicier, but like really kind of separate, kind of like describing them as like an expert in that advanced care planning piece.
Yeah, and most people don't understand that the majority of people that need palliative care are not dying. We could get that concept across.
Yeah, and it's okay, early stage dementia. I mean, does that make sense? You know, given Barak's presentation, tying it to that, like actually having it earlier when the person can contribute is better.
Yeah, you know, we're getting people 5 and 6 days away from dying with advanced dementia. Yeah.
So yeah, and then I think we were told differently too. Like palliative care, you could still go to the hospital or something.
Oh, absolutely.
This is not. And then when we got to hospital, it's like, why is he here? You know, it's like I felt like the providers did not know the difference between hospice and.
He obviously didn't. or understand symptom management trained. That's unfortunate. Allison.
Me, I also wonder how well equipped everybody is to recognize how pain presents itself in a person living with different stages of dementia, because the question of when is it time for palliative care.
So talk about pain assessment.
Pain assessment for people living with dementia. And then the other thing I would add is how to explaining to people the language to share with families around introducing palliative care.
Yep. Okay, great. Oh, I have it written. Okay, I'm good to go.
All righty.
Make up some slides. This has been a great session.
Yeah, it was really interesting. Kimmy, great job.
Yes, Kimmy.
Good job, Kimmy. Thank you.
Thank you.
Thanks. And thanks, Allison, for teeing everything up.
Yeah, you bet. All right. So I will let Chris and Nancy know that we don't need them anymore.